Want me to? Okay, Nelson and Anthony, is it okay for us to get started, or do you have to make any announcements?
No, you can go whenever you're ready.
Okay. All right. Welcome back, everybody. Just to keep track of where you are or where you should be. This is concurrent session A. My name is Patrick Karen. I'm going to be the moderator for this next session. We have three wonderful presenters who are going to be educating and informing us. The topic of their presentation is When Parents Disagree, the Role of Medical Providers When Caring for Transgender, Gender-Expansive Children, and Their Parents Involved in Custody Disputes. I'd like to welcome our presenters, Cami Bellis, Kate Kuvalanka, and Michelle Forcier. I'm going to turn it over to Cami, who's going to lead us in the presentation. If you have questions, please feel free to use the chat, and we look forward to our conversation together.
Thank you, Patrick. Good afternoon, everyone. It's really nice to see you all. We are one of the last presentations, but certainly not least. So thank you for sticking around and being with us. I am in the Office of Equity, Diversity, Inclusion at the University of Arizona College of Medicine, Phoenix, and also one of the co-directors of the Health Equity Theme. And I'm also the founder of Mothers/Parents in Transition. We support parents around the country who share custody of a transgender or a gender expansive child with a rejecting ex-partner. And I've been doing that for about 8 years. I come with a social justice perspective, a health equity perspective, and a children's rights perspective, and have been working on behalf of LGBTQ youth and adults for the last 15 years. And I appreciate the unique perspectives my two colleagues bring, as we all are coming with a very different lens. And so I will let them introduce themselves, and we'll start with Kate.
Great. Thanks so much, Cami. Hi, everyone. My name is Kate Kuvalenka. I use she and her pronouns, and I am a professor in the Department of Family Science and Social Work at Miami University in Oxford, Ohio. So I've been studying and researching and writing about LGBTQ family issues for almost 20 years. More than a decade ago, in 2008, an affirming mother of a trans child reached out to several LGBTQ organizations looking for a researcher to study families like hers. And I was lucky enough to be put in contact with her. And so we started a longitudinal study of 50 families across the United States. All of them had parents who are generally, and sometimes in some cases, very affirming of their trans children. And then in 2013, I was so lucky to be put in touch with Cami. She was looking for a researcher to study a subset of affirming parents. So parents who were in the middle of custody challenges with non-affirming ex-partners. So through both of these studies, I've learned so much. I've been so honored to be let into the lives of these families. They really are pioneers. They're trying to make the world a better place for all kids. And so I'm really honored that I've had the opportunity to be a part of it. And I'm happy to be here with all of you today. So thanks to everyone for joining us. I'll hand it over to Michelle.
Good afternoon. My name is Michelle Forcier. I use she, they pronouns, and I'm a primary care pediatrician, and I take care of and have been taking care of LGBTQIA+++++, the ever expanding rainbow for about 20 years now. And I'm a very practical person, so hopefully I'll provide some tips and tools to use to frame understanding gender care from both a primary care and a developmental perspective, and that appreciation that human diversity and human growth is normal and wonderful, and something that we know is important for youth to get support as they go through and explore their gendered selves. Those are my financial relationships.
Thanks, Michelle. So just to review our learning objectives, so we want to describe the social determinants of health and mental health for these children and their affirming parents engaged in custody disputes, discuss the ways in which you all as medical providers can appropriately and compassionately navigate care when co-parents disagree, and discuss strategies for being an advocate for these supportive parents and their children in your role as a child health provider. And I'm going to turn it back over to Michelle.
So a mother brings her child for the 8-year-old child wellness visit. Mom indicates to you that in the past few months, the child, assigned female at birth, has stopped wearing all feminine clothes and chooses to wear ties, vests, hats, and clothes commonly seen as masculine. She continues to tell you that the child has asked to be called Jack instead of their legal name. Mom indicates that Jack's father, who she shares custody with, is not supportive of Jack's gender exploration. She says that Jack only dresses this way at her house and sometimes at school. Jack's father calls you the next day and tells you that his daughter is going through a phase and that he believes mother is pushing the child to be transgender. Some questions to consider. What are the thoughts and also some of the feelings that come to mind when you hear this story? What are some of the questions that you might want to ask of all 3 parties involved? And how would you ask them? And how might asking them be different depending on perspective, development, and age? And what might be some next steps in providing care for this youth? Next slide. So the way we've been approaching gender care in our clinic, we use a consent-based, patient-centered framework where we have explicitly talk about We're not gatekeepers. We're here to listen to your child and to better understand who they are so we can provide best medical evidence in terms of supporting your child being safe, being healthy, being happy, and having a long and healthy and productive life ahead. And one of the pieces or frameworks that helps us do that is the reproductive justice framework, which is thanks to Sister Song many, many years ago. Next slide. And the reproductive justice framework is a large framework, but it's really suits gender care because it directly talks about body autonomy and that individuals have the right to make their own decisions about their gender identity, about their sexual activities, pregnancy and parenting. It talks about the right to self-determine where patients make the decision, not necessarily the provider. So this is a little bit different than some other areas of medicine where maybe the urologist makes a decision about when to remove the prostate, but it'd be really inappropriate for the urologist to make a decision about a child's gender identity. That needs to come from the kid themselves. And that was a question I had one time from a urologist. The right to safe, can you go back? The right for safe and healthy environment with opportunities to develop potential. And that's just, what children deserve from adults and from communities. And just a matter of social justice. And then again, responsibility for the most marginalized, where as medical providers and persons that take care of children, we need to be aware and we need to be skilled in taking care of some of our most marginalized youth. Next slide. So children grow up with their inherent biological and inner selves, but they also grow up in the context of families in terms of community and their local environment and in terms of various religious, cultural, et cetera, sort of aspects. What we know from all these things is that when kids are safe and they feel loved and they feel appreciated and they feel supported, they grow up into be healthy adults. Sort of one of those duh moments where of course that makes sense for kids to grow up healthy and happy. These make sense. We're going to talk about why that's important toward the end of my part, just because that helps us again frame how can we intervene and support youth who are exploring gender identity. Next slide. So we know all youth gender play. Gender play is trying things on, it's a passing interest. It may be days, it may be years, but it's a little bit different than gender diversity. Behaviors and expression may be non-conforming or diverse, but children can still feel they're in the right gendered body. Gender diversity, on the other hand, is when children have a longer and more committed, next slide, please. More committed interest and sort of feeling that maybe the gender they were assigned at birth doesn't quite fit who they know themselves to be. In the old days, we used to say gender diverse children were consistent, persistent, and insistent in terms of cross-gender expression and roles, wanting other gender or body parts, not liking one's gender and body parts. We also know and have grown to really appreciate a broader diversity among gender diverse kids, where there's a whole group of non-binary, diverse, and fluid youth who dare to defy these boxes of pink and blue, male and female, and may identify as agender, non-binary, or that the terms that we currently use for gender don't really work for them. So these children and adults can move between genders in a very fluid and dynamic way within hours, days, or other time frames. Next slide. We know that gender identity, which is really, it's a journey. Informing gender identity is many, many steps and many, many paths. The gender book is a wonderful tool to use with families to walk through different aspects of gender identity formation and different concepts and thoughts and ways to process and think about it. It's a really fun book. It takes patients or families through a variety of different sort of open-minded exercises. We use a gender roadmap, and we don't have policies, protocols, or guidelines because we really want to avoid the gatekeeping. We really want to keep this to identity as a journey that you're going to have to go through and figure out who you are along the way and at the end. Next slide. The gender book also has this wonderful sort of gender world where you may live in one part of the world for part of your life, say Manlandia, but then as you go and approach teenage years, you might realize that Ladylandia is a much better fit. There's the agender satellite that likes to float around the Earth. There's the gender fluid cruise ship that zips between different islands and different continents. But this is a wonderful book, again, to help parents understand the dynamic and changing aspects of gender identity. And I really recommend it. It's also publicly available. It's just a great resource. Next slide. So Jack and his parents come in 6 months later. Jack comes dressed in baggy sweats and looks anxiously between mom and dad. Mom indicates that Jack's father, who she shares custody with, is not. This has created tension and anxiety for Jack and for the two households. Dad reports his faith does not believe in transgender and he will not go along with Jack's requests while Jack spends time at his house. Alone with the providers, Jack tells them that he's the boy, he knows this. He says it makes him sad that his dad won't let him cut his hair or wear the clothes he wants to at home, but he's just a kid, so what can he do? And this is a really recurring theme where kids will often not challenge a rejecting parent or even an accepting parent because they're just so afraid that they're going to disappear from care if they don't perform, if they don't make their parents and please their parents and make their parents happy. So just because a child is not necessarily telling one parent that how they feel and that they're transgender doesn't mean that they're not experiencing it. They often really read the room carefully and they really can understand this isn't a safe place for me to bring this up. So just because kids are talking about it with a parent doesn't mean it's not an issue. Next slide. And these obviously are issues very, very unfortunately relevant today with multiple legislative efforts and other transphobic cultural, legal, political wars going on that put our children at risk for not getting best care and best practices of care. Next slide. The slide before I liked with battle because this is a battle for many children and adverse childhood experiences can result from many of these battles where children are subject to emotional or verbal abuse because of their gender diversity, physical or emotional neglect. We know that children and youth who are gender diverse are more likely to experience homelessness and single homelessness as a young person for substance abuse. We know that trans persons and trans youth are more likely to face discrimination, difficulty with jobs, poverty, and a whole host, again, of negative effects that then create difficulty as they move through other expected developmental nodal points in terms of developing healthy sexuality, healthy relationships, and risk-taking. And so ACEs is a really good framework to understand that again, these external experiences that children go through, again, do have an impact. And there's nothing wrong with being transgender. It's the effect of these outside forces on you and how they affect your growth and development. Next slide. I like ACEs in the trauma-informed care, again, as another tool to sort of help guide how should we provide care? What are the structures for providing care? With trauma-informed care, we know there are 3 E's: the events that occur, the experience that the person identifies and remembers and feels and the effects of that event and experience in ongoing relationships in life. The 4 R's of trauma-informed care are realizing the widespread impact of trauma and understanding the potential paths for recovery, recognizing signs and symptoms of trauma in families, patients, staff, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and resist re-traumatization for children and adults. And the way I apply this in clinic is an example of this is, say I'm doing a physical exam. It's a new patient and I might need to do a physical exam for that patient. I talk to them about how I need permission to do this exam, what parts of this exam would they like me to do or not do. For adults, I'll often speak of the medical trauma that institutions and systems have created for trans and queer persons. And again, talk with them about these are options for parts of your exam, you're in control of your body, these are the risks and benefits of doing or not doing these things, and they get to sort of select what makes sense and what they feel safe with. But I find that the trauma-informed care model really opens up a discussion about what patients want and expressly helping patients feel safer. Next slide. So at the 1-month follow-up visit, mom reports that the difference in parental responses to gender exploration are making it hard for Jack. She says Jack complains that he does not want to go to his father's house. Jack reports to you that dad does not allow him to wear his comfortable clothes and refuses to use his new name, which is distressing. Mom supports Jack's experience. In private, she reports that Jack's distress is also hard for her. And I can tell you as a clinician taking care of these kids, Jack's distress is often also very hard on the providers. And I think acknowledging that impact on those of us who are giving care. She reports Jack's father threatens to sue for sole custody, as well as reporting he will never sign on to gender care. What might you consider in approaching this family and next steps? So what happens when parents don't affirm? Well, again, another tool from which to approach providing patient-centered consent-based gender care is minority stress theory. And again, it externalizes where the harm and pathology comes from. That social stigma is associated with minoritization, and that family rejection, social isolation, lack of acceptance, fear, prejudice, and discrimination lead to invisibility, lack of models, lack of connections, lower self-esteem, and internalized transphobia. This creates minority stress, a daily constant stressor in people's lives, which is linked to the host of negative mental health and physical health outcomes. Next slide. What happens when parents affirm? Well, the contrast is striking. And again, I'm going to go through just a couple of different studies. The studies are consistent, insistent, and persistent about parental support is key and wonderful in terms of when you're working with a family, explaining to a parent why it's so important that they support and listen to their child. And that as their child looks them in the eye and says, I am transgender, it's not okay for a dad or a parent to say, I don't believe in transgender. This is your kid talking to you, telling you their experience, not asking you to believe in Santa Claus or the Easter Bunny. So we have to break it down. Again, that parental support is critical to healthy outcomes. And again, this is the AAP Gender Affirming Care Report, where both reparative therapy or live in your skin, as well as watch and wait, which has its own stigmatization, is not okay. And that it says that parents and providers need to carefully listen, carefully explore, and allow children to move through their process of gender identity formation in a safe and supportive environment. Other studies that are really important is the Russell 2018 study that says using asserted name and pronoun has protections against suicidality. Again, it's not just me saying you should do this because I'm a gender provider. by acknowledging your child and using their asserted name and pronoun, you will keep them from being suicidal. That's huge. And the data to say that to families has been really helpful. It's not a choice. This is a medical recommendation. Turbin in 2020, again, access to blockers in a large study, protective against suicidality. Then there's the Ryan and the Olson studies, and the studies will continue on. I'm very confident, again, that we'll continue to see how important parents are and the benefit of parents affirming a gender diverse child. Next slide. This is the Olson Trans Youth Project. We're essentially, to bottom line it, these are young kids who were supported in early social affirmation. And in the end, as they're studying them over time, they look basically identical to siblings and peers in terms of depression and anxiety, maybe a little bit higher anxiety. But this is striking compared to historical gender data and transgender data, where depression and anxiety are off the roof. Incredibly higher rates than their cisgender or non-minoritized peers. The Family Acceptance Project also is a really interesting study. It basically looked at families, and they asked if parents were a little bit less rejecting, they could show there was benefits. So parents don't even have to say, I love my kid that's trans, yay, diversity. They just have to decrease the lack of acceptance and rejection for kids and adults to have good health benefits. You can put it in a positive frame for parents, which is if you accept your child as they are, regardless of whether you understand it, whether you like it, whether it fits with your religious beliefs, your kid is going to be protected against depression, suicidality, substance use, and a whole host of negative outcomes. And I think that's a really important message. You don't have to understand everything. You don't have to like everything. But from a medical perspective, parent acceptance is a strong and consistent recommendation. Next slide. So again, this provides us with opportunities for intervention. Again, if we know that social stigma associated with minoritization and lack of family support has a huge impact, then we want providers to be talking with kids about gender early on. In fact, we want providers, pediatric providers, when a parent says, well, I just had my ultrasound and I'm going to have a boy. And you might say, well, your ultrasound suggests that your child will be assigned male at birth because they have a penis right now. But guess what? We're going to have 20 years or more of figuring out along with them their gender identity and where they're going to go. Talking about gender at these nodal points of child development. Asking teens, how do they feel about puberty before puberty even occurs? How many of you had a pediatrician or family medicine doc say, you're 8, 9, or 10, puberty is going to be coming down the road. Let's talk about it. Let's talk what it means to you. Not many people raise their hand when I ask that question, sadly. And we're missing opportunities to normalize gender conversations and introduce the idea of there are people who can talk to you about this and support both parents and kids if there is any interest or need or dysphoria as they're exploring their gender identity. And again, early intervention in terms of identification, resources, and support seems to be linked to improved health outcomes. Again, lots of hopeful news, I think, for the future.
All right, great. Thanks so much, Michelle. So I'm up next, and I am going to briefly summarize for you our research that was reported in this article. And then I'm also going to share with you some preliminary findings from our latest work that has not yet been published. So in fall of 2016, I interviewed 10 affirming mothers of trans children from across the United States. All had experienced custody challenges with their ex-partners involving their trans children. All the mothers identified as white, except for one who was biracial, and their 10 children ranged in age from 5 to 15 years old. 7 were assigned male at birth, 3 were assigned female at birth, and 7 of the kids were white, and the remaining 3 were biracial. 7 of the 10 kids had received a diagnosis of gender dysphoria, or GD. 2 of the children had not been given a diagnosis of GD. So one mother thought that her 6-year-old was too young to be given a diagnosis, and the other said that her ex-partner refused to have the child evaluated for GD. And one kid had a diagnosis of unspecified GD because the child would assert a trans gender identity with the affirming parent, but then would be unclear about their gender identity with the other parent. So we can go to the next slide, Cami. So this table is from our article, and it gives a bit of a summary and overview of the custody situation of the participants at the time we interviewed them in 2016. So 2, as you can see, 2 had sole custody, 4 had lost physical and or legal custody, and 4 had a shared custody situation. So of the 10 mothers, 7 of them had their custody decision decided by a judge. And of those 7, 1 had sole custody, 4 had lost custody, and 2 had shared custody. So the one mother who went to court and ended up with sole custody, she said that she felt like she just lucked out with a knowledgeable judge, so a judge who knew about trans identities. Of the 4 who went to court and lost physical and or legal custody of their children, 3 had been the primary caregivers of their children prior to the custody challenge. And then 2 were allowed only supervised visits with their children. The 2 mothers who went to court and ended up with a shared custody decision said that, of course, it was better than losing custody, but it wasn't ideal to have their children going back and forth between an affirming household and a non-affirming household. And then 3 of our participants didn't go to court. So 2 of them had negotiated shared custody. Both had considered going for full custody, but they were scared to do so. And the last participant who didn't go to court had sole custody. She said that the father didn't have much money, and so he didn't take her to court. He had threatened to do so, but he ultimately did not. So we can go to the next slide. I'm going to share just briefly our 6 main themes that we found through our analysis. So the first one was blame. So all 10 of the mothers said that they were blamed by their ex-partners for causing the children to assert trans identities. So some ex-partners claimed that the mothers had psychological problems due to current or past trauma or mental illness, and that these issues were the cause of the children's gender nonconformity. Second, 9 of the mothers described coercive and manipulative behavior by ex-partners. So sometimes these behaviors were directed at the child and the child's gender. So for example, one mother spoke about how her ex-husband forced their child, who was a girl, to get all of her hair cut off, and how he took away her favorite clothes and any toys that he perceived to be for a girl. In some cases, the coercive behavior was directed at the mothers. So some mothers described ex-partners as emotionally and psychologically abusive and as using the courts to further manipulate and control them and to ultimately block affirmation of the child's gender. Third, we saw what we described as transphobic bias in the courts. So 6 of the mothers provided examples of how judges and other influential family court professionals were either uneducated about or hostile toward transgender identities. So for example, the court ordered some mothers to remove the children's favorite toys and clothes from the home, or to not let their children play dress up at home. Fourth, there was a negative impact, of course, of the custody challenges on the children's well-being. It wasn't surprising that just about all the mothers spoke to this. They gave examples of concerning behavioral and physical problems, such as temper tantrums, their kids experiencing sleep problems, not eating, and 2 of the children talked about or threatened suicide. Fifth, the participants also talked about the negative toll that this took on themselves. So the emotional and psychological toll of the custody challenges. Some also spoke about the financial toll that the costly legal challenges had on them. So a few were just financially devastated, so much so that they had to be on state assistance. And lastly, just about all the mothers spoke about the critical need for adequate resources, such as money. So how, having it or not having it could make the difference between keeping or losing their children. And they also talked about the need for and the importance of having better educated, unbiased family court professionals, which is why we're here today. If you can go to the next slide, Cami. So this past summer, I completed follow-up interviews with all 10 of the original mothers in our study. So this was about 3.5 years after data collection for the first study. So the purpose of our follow-up study was to find out if and how the mother's situations had changed. So if they did get better or worse, we also wanted to see if we could figure out why. So we've just begun data analysis on the interview. So what I'm going to share with you are just preliminary takeaways and findings based upon my several readings of the transcripts and my interview notes. So 5 cases seem to be better at follow-up. So 4 of these were the most heartbreaking cases that we had at time 1 in terms of mothers losing custody or having their time with their kids drastically reduced or not being allowed by the courts to affirm their children's gender. So those mother situations had improved, at least from a legal standpoint. In one case, shared custody was restored, and that mother also no longer was required to have her time with her children supervised. In another case, the first thing the mom said to me when we got on the phone was, "Kate, I've got my kid back." So there were drastic improvements in some of these situations, but they certainly were not perfect across the board. So for example, one of the mothers still had restrictions on her. So physical custody was restored, but she still was not allowed to discuss anything gender related with her child. Another mother no longer had to have supervised visits, so she was able to have her child stay overnight once a week, but she was essentially cut out of most of her child's life. The mom said that she feels more like her child's babysitter than a parent because of how little time they have together and from the trauma of the separation that they endured. Also, when asking why these situations for these 5 mothers improved, it's important to note the cost. So what it took to get to this better place. And so 3 of the mothers spoke about how it took the court seeing severe deterioration in their children's mental health and physical well-being. And that was what led the court to change the custody orders. So 2 of the children between the initial interviews in 2016 and our follow-up interviews had attempted suicide. So one of those children at time 1 had talked about it and had warned others that they were contemplating it. And then later they actually carried through with it after they were forced to live with a non-affirming parent. So the mother said, luckily they were not successful with the attempt. The mother said that it took her child's suicide attempt and subsequent hospitalization to get the court's attention. The other mother said that it took it took her son trying to kill himself after his father forced him to live as a girl for the court to restore joint legal custody and for the court to order the father to comply with gender experts' medical recommendations. So 3 of the 5 mothers whose situations had improved, they attributed the positive outcomes to a change in the family court professionals who were assigned to their cases. So one mother no longer had to deal with what she referred to as a biased judge, and another now had a guardian ad litem who seemed to be able to see past her ex-partner's controlling and manipulative behaviors. So unfortunately, 2 of the mother situations seemed to get worse between time 1 and the follow-up. For one of the mothers, the situation moved from shared legal custody to complete loss of legal custody after the ex-partner sued for it. And the ex-partner said that the affirming mother was making unilateral decisions when it came to the child's gender. Both of these mothers are living under constant threat of litigation and fear that they will lose their kids. They both want to support and affirm their children's trans identities, but they can't. So one mother's attorney told her to back off the gender stuff because she may lose the remaining 50% of custody that she has. So when we were trying to figure out why, what's going on with these 2 cases in particular and why have they gotten worse over time. So first, it's important to note that these 2 kids were among the youngest in our study. So they were both 5 years old at time 1, and they were just 8 and 9 years old at the follow-up. So that plays a role possibly in that these 2 cases may just not be as far along as some of our other cases that we've had that were bad, but then eventually got better. But the children's age also plays a role in that the court seemed to be persuaded by the ex-partner's arguments that the children are too young to know their gender. So in these 2 cases, the ex-partners are telling the courts that they're open to their children being trans, but that it's just too soon to know if they actually are. So the ex-partners are arguing that no one should use the pronouns or names that the child says that they want everyone to use, because if those pronouns and names reflect a binary trans identity, the ex-partners are saying that that it's because the mothers are pushing the binary trans identity on the children. So unfortunately, the courts seem to be accepting this argument and have sided with the ex-partner's request to go with a gender neutral approach rather than following the child's lead. So in at least one case, the court has ordered that no pronouns be used to refer to the child. So the court seemed to see a gender neutral approach as prudent and as doing no harm, but the mothers in our study are arguing that this approach is not affirming their children's asserted gender, and therefore it's not in the best interest of the kids. So before I hand it over to Cami, I do just want to mention one thing. One question I get asked a lot is, how common are these court cases? And that's a question, unfortunately, I can't answer because I just don't know. But I also think it's important to note that focusing only on the cases that go to court, it misses the complexity of what's happening in many families. So just to illustrate, one mother in our study who had shared custody and never went to court, she regrets never having pursued full legal custody. So her child was diagnosed with gender dysphoria at age 6, but the child didn't receive gender affirming medical treatment until the age of almost 18 because the father wouldn't allow it. So the mother never pursued full legal custody because she was terrified that she would lose her child completely. So there's so much more for us to learn, obviously, in many ways that health providers like yourselves can be advocating for trans youth so that these affirming parents don't have to be afraid to ask the courts to help them do what is in their children's best interests. That's all for me, so I'm handing it over to Cami.
Thank you, Kate. So they did a really good job of setting things up for me. So I'll be discussing the root causes or structural issues impacting these cases, and then also presenting the toolkit that we have. So they did a really good job of highlighting what happens when children aren't able to authentically be themselves, and what the research tells us. I'd like to start with what I call the when parents disagree spectrum. So on one side of the spectrum, you have your run-of-the-mill parent who initially isn't on board, but with time generally comes around. They might go to therapy, they might read some books, they might go to a transgender, parent support group.
Sorry, Cami, it looks like
we lose.
it's frozen.
Oh, Cameron, we lost you for a second.
Am I back on?
You're back. Yeah. So if you could just go back, rewind 30 seconds, I would say.
Okay, can you hear me?
Yes, we can hear you now.
Okay, so I guess I'll just rewind to generally these parents on this side of the spectrum can come around with time. That's not really what we typically see. What we see, and from the dozens of parents I've helped around the country, is this other end of the spectrum, which illustrates that most of these cases really that we have seen and supported where one parent, the unaffirming parent, uses the family court system to power and control the other parent. In most cases, there was intimate partner violence, mainly emotional abuse, but there can be physical abuse as well. And that this violence continues post-dissolution of the relationship. The rejecting parent uses coercion, manipulation, custody threats, and blames the other parent for the child's gender nonconformity. Supportive parents are often reported that they are railroaded by the rejecting partner or rejecting ex-partner and court professionals, and are gaslit, which are psychological manipulation terms for those of you who are familiar with them. So for example, saying such things like, I never tried to take your custody away, or I support my child, when all the evidence points to the contrary. So when we look at these cases with this spectrum in mind, the myth that pervades in family court is that both parents are contributing to the high conflict case. And that really needs to be questioned. When there is power and control and the child is used as a pawn to further abuse, And gender just happens to be the main issue. This is not a general case of custody. For these parents, it has been months, if not years, for many that the rejecting parent refuses to affirm. So this idea that we sometimes hear from family and medical providers, or I'm sorry, mental and medical providers, is that, okay, with time, generally parents come on board, and that might be your general run-of-the-mill parent. That is not what we're seeing. We know some parents that never get on board. So this is the typical trajectory for many of the supportive parents and can end one of three ways. And so you'll see that the child will express gender nonconformity or gender expansive play with one parent. The other parent, and that parent affirms or supports the parent in their home. And then the rejecting or abusive or the other parent will either hear about it, or the affirming parent will try and explain it to them, or the child will come out to that other parent and they get upset. And so they file for custody. And then there are court proceedings, which can be having a best interest attorney or guardian ad litem, court therapeutic interventionists, custody evaluators, therapists. And then what can happen is the affirming parent gains full custody, which, as Kate said, is pretty rare. The affirming parent can lose custody, or there can be joint custody. And so it's much more common to see the affirming parent lose custody. In some cases, joint custody is restored, but actually the conflict continues because both parents still have legal decision-making over medical and education, unless one has a final say over a particular aspect, which we have seen. What would be an ideal outcome, like Michelle had talked about, was that the child is that for both parents really affirm and support the child and come to agreements that are in accordance with current medical recommendations. This is generally not what happens due to interpersonal and institutional transphobia in the family court system. We have seen some cases where with an adolescent, the affirming parent will fight for puberty blockers or cross-sex hormones, and the unsupportive parent may sometimes agree. And I use that term really lightly. They kind of grudgingly agree because they have a teen on their hands and the teen is saying, I don't want to see you anymore. You don't support me. I want nothing to do with you. And, and they really advocate for themselves. They're also older, so the courts tend to, unfortunately, listen to them more because they are older. Here are the three components that we initially thought were interacting in these cases. And so we have coercive control, which is a form of intimate partner violence and generally gender-based, identity-related abuse, and institutional and interpersonal transphobia. And then we realized there is a lot more going on. So when we dig deeper, we see it's much more complex. While those components make up the root causes, there are other adverse childhood experiences, ACEs, like Michelle had mentioned, or trauma that occur for these children, including determinants that lead to health and mental health disparities, many of which you are already aware of. So the courts want to focus on high conflict, or even, is the child really transgender? When in reality, we're dealing with complex issues that need to be addressed and mitigated. So as you can see from this conceptual model, these youth and their supportive parents are really facing an uphill battle, especially when you add in additional determinants like denial of scientific evidence, implicit bias, and the current political climate. I would be remiss if I don't point out how much more challenging it is for our Black families and those that are gender diverse or gender or trans themselves as the parent with a trans child. So this work really needs to be intersectional. We work hard at it being intersectional. I helped a parent in a southern state a few years back, and the judge actually said in open court, a lesbian mom and a transgender child, something is wrong with this picture. So it's 2021. If you think that judges are not biased, I think people need to be attuned and open up their eyes and realize that this is exactly what's happening. So here's an example from the interviews Kate conducted that highlights coercive control. Oftentimes the child is used as a pawn to further abuse and control the parent, in many cases an affirming mother. And so he was really controlling, and I was always trying to be perfect for him, but I had been with him since I was 16. He will never be satisfied until I'm almost just like gone. I feel like he gets pleasure out of hurting me. He will never let me have my child. He will never let me have a life. I'll always be fighting against him. So identity-related abuse, which we and others put under the trauma or the ACEs umbrella, is defined in the literature as physical or emotional abuse in relation to gender and gender presentation. And so this can manifest in a variety of ways. Making comments, negative comments about the child's appearance, accusing the supportive parent of abuse. Kate mentioned some of these things that they can do. And we know that this stems from transphobia, and in many cases, abuse aimed at children assigned male at birth. So we've put together a toolkit for medical and mental health providers to support your understanding of and care for trans and gender expansive youth and their supportive families engaged in custody disputes. You'll find the toolkit in the Google folder link in the chat. This is version 1. We had really big plans about 2 years ago, and then COVID hit and it was put on hold. We'll be working on a second version that's a little bit more robust, hopefully by the end of the year, that we'd like to publish. And I anticipate online modules to go along with the toolkit because we know additional training is really needed. I want to thank the co-authors on the toolkit, not on this presentation, who's Dr. Vinnie Chulani at Phoenix Children's Hospital and Dr. Suzanne Kingery at the University of Louisville School of Medicine. And also shout out to Dr. Laura Weingardner for her support and guidance. So we know that family court professionals are increasingly turning towards medical and mental health practitioners for guidance and recommendations when parents disagree. So we wanted to provide you with a resource as you navigate the care and complexity that comes with these cases and feel a little bit more empowered to advocate for your young patients. You may not work directly with youth, but this is still really incredibly relevant. We're all here to advance LGBTQ health equity. We need allies, we need providers to intervene in these transphobic systems and educate themselves about these issues. So here are the few of the toolkit takeaways we thought were important to highlight here. The first is to understand the complex dynamics of these cases. This is not just parental conflict. This is systemic and this is harmful. And understanding the complexity of these issues will help you better advocate for these youth and their families. So really dig deep into the systems that we are a part of. Is your clinic or institution prepared to handle these cases? Are there clear policies in place when one parent refuses to consent to treatment, but the child is suffering? What are the policies on testifying in court on behalf of your patient? A lot of clinics, including mental health providers, will not take on these cases, and I'm going to call them out on that. We do not need providers turning these families away because they don't take on these cases or I don't touch these cases. Do not perpetuate harm. Get educated and trained on these issues. We want you to be a part of the solution. Call out transphobia. This can be very subtle in these cases if you aren't trained to see it. And so we'd like to start kind of teaching you how to flex that muscle of when you see transphobic behavior or when you hear it mentioned. Here's some examples. This is what interpersonal and institutional transphobia looks like in medicine and law. As healthcare providers, it's your role to call this out, to name it, and educate the courts about these harmfulness because you're in a particular position to do that. And so kind of like what we mentioned, the court professionals stating the child's too young, having court orders that take away affirming things, toys in the home that the child likes to play with that are quote unquote gendered. Using CPS as a weapon to falsely allege child abuse against the affirming parent. And then we'll hear medical and mental health providers and family court professionals making up bizarre words, such as the child is in remission if the child goes to another house and doesn't assert their gender identity or is just feeling too pressured from the unaffirming parent to kind of go back in the closet. And so those are just some examples. Follow current standards of care. Many of you are familiar with the WPATH standards of care and the Endocrine Society. We want to follow current guidelines that recommend supporting families to provide nurturing and encouraging responses when children are exploring their gender and gender expression. Parents may find it stressful that their child is ambiguous or gender fluid. We get that, and we want to acknowledge that. We know that in an interdisciplinary setting, the mental health professional in conjunction with the endocrinologist or the primary care provider can more holistically address parental concerns and support families through the transition process. This means all clinic staff should be trained on these issues. Navigating parental hesitancy. This is a really delicate balance of supporting the child's gender identity and expression and not alienating the unaffirming parent. As a provider, it's important to continue to validate and affirm the child's gender identity and expression in a safe clinical environment. And then we also know that you play a really key role in encounters by addressing these concerns with current evidence-based medical knowledge. This is where those individualized care teams can be really important. Listen to and center the child. This is probably one of the most important points and a very delicate point. We want to listen to what the child is telling us about their gender and what they need, and really attempt to remove the noise that's around them, meaning the parents. What's parent A saying versus what's parent B saying? Well, what's the child saying? What's the child saying? How are they behaving? Unfortunately, what happens is that we have clinicians or therapists saying, well, the child said one thing and dressed one way when mom brought them and this way when dad brought them. And the child is changing their mind, and we can't make an accurate assessment. And I urge you to ask yourself, what seems more logical and reasonable? A child pretending to be trans, or a child scared of a parent's reaction to their gender nonconformity so that they really aren't their true self when they are brought to the clinic by an unsupportive family member. And so, yes, super important, to realize, to center the child and really kind of challenge some of those assumptions. And then also oppose harmful court orders. As Kate had mentioned, this happens a lot. So we see that attorneys and parents are filing motions to the courts, ordering affirming parents to not support their child, to remove items from the home that are really important to the child. These are transphobic orders and have no place in family law. As medical providers, when you are asked to testify, it's imperative that suggestions and orders like these be challenged and called out as harmful. So we recommend.
Sorry, Cami, your camera froze again.
I think Cami is completely frozen at the moment, so hopefully it will catch up and they will come back.
Am I back?
You're back now.
Okay, sorry about that.
It's okay, we only missed about 10 seconds. It's
okay.
Cool.
Well, I will really kind of end there with, we need medical providers to be pulled in earlier so that we don't have transphobic court orders like this. I know we've covered a lot. I appreciate you all being here and learning about this population. We'd like to open it up to comments and questions.
So Cami, Kate, Michelle, thank you so much. This was a really powerful presentation, and you've given us a tremendous amount to think about. And thank you again. We've shared, with their permission, the materials that were referenced